Hey everybody, this is Miss Nicholson, and I'm coming to you today on the concept of oxygenation. And oh, how well I can speak to this lately. So it is very vital, and our respiratory systems are precious, and we need to take care of them. But without the cardiopulmonary combination, we got to have the lungs, but we also got to have the respiratory system. We also got to have the heart and blood vessels to oxygenate our tissues. So you really can't talk about one without the other, and these will overlap a good bit in parts. The concepts of oxygenation and perfusion. So this will be our approach. We're going to hit it from the respiratory side, and we have to mention the perfusion side of it occasionally to get the concept to go in your head, or even my head. All right, so here's the definition by Hines. It's the process of providing cells with oxygen through the respiratory system. It's accomplished by three different mechanisms: pulmonary ventilation, respiration, and perfusion. And all of us, you can start thinking of yourself as a nurse now. And everything you do, you need to be looking at all these case studies, all these patients in clinical, and these are problems, these are alterations, and you're seeing lots of alterations in oxygenation at this level, which is not always the case in first semester. You can really start submitting some of this stuff and never forgetting some of these patients, but you're going to be dealing with patients with oxygenation issues, and you need to detect it early. And you need to intervene early because, I mean, it's only a few minutes and the tissue's dead. The brain is irreversibly, once it's dead, there's nothing else you can do. You can't regrow the brain. Same thing with the heart. We only got a few minutes. We have small windows of time to get that oxygen flowing back to the tissues or it's going to die and you can't replace it. So catch it early. Let's talk about the three processes just a little bit. Oxygenation, your book. Most of your materials come from like chapter 39. And that's what I assigned and highlighted and shared with you guys in Lippincott. But ventilation is the first process, or pulmonary ventilation. It's the mechanics, in my opinion. It's kind of how I have to put things in a type of analogy to finally get some of this to go through. This is where your body's going to be breathing in and out, breathing the oxygen in and expelling the CO2. And anything that obstructs the respiratory tract can lead to impaired oxygenation, like even the nasopharynx can get stopped up, your lungs can get stopped up. Let's see, COPD, edema in the sinuses. I mean, God forbid you have a patient with anaphylaxis and they have tracheal edema, okay? So that would impair ventilation, getting the air flow in and out. The second process is respiration. Now, forgive me if I sniffed, cough, I'm so sorry. But respiration is where the gas, this is at the cellular level. Ventilation's, the mechanics, the actual in and out that you can see. But this is the part that you can't see. But it's so important that you understand that gas exchange between the atmosphere at the alveoli and the blood in the capillaries is so important. So whatever's going on down at that small cellular level is so important, because if you're not getting that gas across, even if you're breathing it in, if you're not getting that oxygen across, then you're not oxygenating the tissues. And sometimes that's what we have to deal with, and especially the COVID and those types of crises that we're dealing with right now. And we have to consult our respiratory therapists and use all different types of oxygen modalities to get these patients their oxygen levels where they need to be in the blood. But then also your body's got to be able to transport oxygen. The hemoglobin has to have the ability to deliver it, and so if it can't deliver it, the other job it's supposed to do is pick up the trash, pick up the CO2, and that can cause problems with oxygenation. And that's where you guys will be talking about anemias. There's so many kind of problems with their transport for different reasons that lead to anemia, and that can cause oxygenation issues. And you'll talk about that in third semester, I believe. So we're building on that. And then there's the perfusion. I think it's Miss Pittman has that content. She does a really good job with it. We're trying to introduce it earlier. We will build on this concept with some more exemplars in second. So this is not going to be the last time you see oxygenation. So this is just a building block. Perfusion is the process where oxygenated capillary blood passes through the body tissues, the cells and the organs. But you got to have a pump to maintain. So your heart, your blood vessels have got to help us to get those that oxygen to the tissues. So we've got to maintain blood pressure and blood volume. Any impairment in that can, for whatever reason, it might be decreased cardiac output. Maybe they've got heart failure. Maybe it's a thrombus or clot, or maybe it's a constriction of blood flow, or maybe it's even bleeding. So there's various things. So if you can learn to conceptualize these things, you can kind of group some of your interventions based on, where the problem's at on these processes. So that's the way you've got to try to embrace concepts. And so let's move on. The demand for oxygen, it has to be met by the functions of the respiratory and cardiovascular system. Make sure you review A&P of both systems. When you combine respiratory and cardiovascular, we call it cardiopulmonary system. The heart and lungs, they got to work together to oxygenate the tissues. And I've kind of already mentioned this, but if you don't understand this term, ischemia is what will result. Which is called death of tissues. That's a lack of oxygen to the tissues, and tissues will die if we don't intervene. So make sure you spend some time and watch this normal A&P video. I think I posted another one in the module. And there's factors that are essential to normal functioning of the respiratory tract. So you've got to have an airway system that has its full integrity to transport air from the outside to the lungs and out. Got to have properly functioning alveolar systems in the lungs to help oxygenate venous blood and take that CO2 out. Properly functioning cardiovascular and hematological systems to carry these nutrients and waste from the body. You've got to work in conjunction, like we've said, with the circulatory system. There's the upper airway system and the lower airway system. You need to go ahead and, if you won't remember from A&P, the structures, you need to review it. We will here shortly, briefly. But the whole purpose of the upper respiratory system or the general purpose is to warm this air and filter the air that comes in. So there's a lot of protective mechanisms. We have hair, and we have mucus, and we have cilia down in our lower respiratory tract. We have enzymes and in our mucosa to protect us. And then the lower respiratory system's general accomplishment should be to exchange gas. You got the lungs, the chest wall, the diaphragm. They are responsible for your ventilation. So moving on to the upper airway. Already kind of talked about the function, but it begins at the nose and ends in the terminal bronch. That's just the airway in general, but it's divided into two different upper and lower. So from the nose to the terminal bronchioles, at the ends of those, that's your respiratory tract. And you have those external functions that support it, like your chest wall, your diaphragm. But it's the pathway where this exchange of oxygen and CO2 is going to happen. You got your nose, your sinus passages, nasal passages, your pharynx. The pharynx is also considered part of the GI because it's where food is taken in. You got your tonsils and your adenoids if you hadn't had them removed. And sometimes that has to happen because they do obstruct and cause chronic problems. But the larynx has the epiglottis, glottis, vocal cords, cartilages, and the trachea is kind of the cutoff line, is what I try to say. That's where you start into the actual lower respiratory tract. But the epiglottis, if you remember from A&P, and y'all didn't throw those books away, I hope. But if not, use your resources to always review your A&P. The epiglottis is what protects the airway when you take food in. So that is the upper airway. And I have a good picture here coming up of it. The lower airway is also known as your tracheal bronchial tree. Includes your trachea, your right and left main stem bronchi, segmental bronchi, and then your terminal bronchial, which are the end. Its major function is to conduct air, provide mucociliary clearance, and to produce like pulmonary surfactant, which is pretty cool stuff. The airways are lined with mucus. Ooh, sometimes really lots of mucus. But it traps cells, particles, debris, irritants, and the mucus covering also helps protect the underlying tissues from irritation and infection. So thank God for it. But it is in copious amounts sometimes, or especially early in the morning, and depending on what's going on with the client. So we want to promote mucociliary clearance by increasing fluids and things like that. We can talk about that a little bit later on. But the cilia is those little microscopic hair-like projections. They're in the lower airway. They propel trapped materials. They kind of do the sweeping. They clean house, and any mucus that's attached to those trapped particles, you know, it helps move it out. You may have, it's what kind of brings it up so you can cough it out. So removal is usually facilitated when the mucus is kind of watery in consistency versus very dry and thick. So adequate fluids are usually necessary for normal present functioning mucus in the respiratory tract. All right, we're still talking about the anatomy of the lungs. There are 5 lobes. There is 2 on the left, 3 on the right for normal individuals. You have the pleura is also involved in the lungs and is a membrane around the lungs, and it helps with movement, decreases friction. You've got to keep that membrane, it has to have fluids in it to do its job and keep everything gliding, opening, and closing. Mediastinum is involved in the lungs and chest. You've got bronchi, bronchioles, and then the alveoli. We are born with, I think where I read, 300 million of those little jokers. Here's a good diagram. You've got to have pictures to kind of help you when you're reviewing A&P, or at least I do. I'm very visual. But sinuses are considered part of your respiratory tract. Oh, how problematic they are, especially if you have the nasal allergies. Infections that you need to understand in the lower respiratory tract always usually originate in the upper respiratory tract. So we got to take care of that. You know, provide oral care, take care of those sinuses. I have a subsection here pulled out of the alveoli in this diagram. That's exactly where gas exchange occurs. The fusion of oxygen and carbon dioxide happens at that alveolar capillary membrane. See those vessels wrapped around those little alveoli sacs? It's very delicate. Our lungs are so amazing, but also so fragile. And you have to have, there's different types of alveolar cells, and they have jobs, and surfactant is produced there. And you'll hear about that again when you talk about babies. When they're not full term, they may not have enough surfactant, and so we may give them some things to the mother before she delivers, hopefully to increase their surfactant. But it keeps those little bitty air pockets from sticking together. It's kind of like a detergent type base there, where it helps those sacs slide open where they don't stick. And atelectasis is collapse of that unit. We want to avoid that because we need that surface area to pick up that oxygen and also drop off that CO2. But there's a main bronchus that branches off into each lung, and immediately goes ahead and divides into some secondary bronchi, 1 to each lobe. Makes good sense, don't it? We're amazingly made. The bronchi subdivide again and again and become smaller and smaller, and they branch throughout the lungs. The smallest of these branches are called bronchioles. And you hear a lot of that term used with pediatric patients because their bronchospace is so small. And then the bronchioles into the terminal bronchioles. The lungs are composed of very elastic tissue that helps them stretch and recoil to do this massive work that we have to have done every day, many times a day. And so I just talked about the alveoli. Its singular word is alveolus, in case you see that in some type of question on Preppy or whatever. Alveolus is singular. Alveoli is plural. But the wall of each of these is a single cell squamous epithelium. It's very thin. So it's just for the main reason to allow this exchange of gases. And let's see. I think that's really kind of all I want to say is, we've got to keep our airways moist. Let me see if there's anything I need to add right here. Other than talk about the pleural space a little bit more. It's a serous membrane that lines the lungs and thoracic cavity. You also have a visceral pleural that covers the lungs. The parietal pleural is the other side of it. It lines the thoracic cavity. And in between those membranes, you've got this continuous flow of sac, and inside of it is fluids to help lubricate it. And it also acts as an adhesive agent to help hold those lungs in an expanded position. There's only a few milliliters of fluid in that space. It's just amazing how our lungs are made. But it allows the lungs to move easily along the chest wall as they expand and contract. And so without this fluid filling and emptying the lungs would be very, very difficult. So thank you to the pleural membranes. You need to understand that there's pressure within those pleural spaces that's below the atmospheric or subatmospheric. And so we have to maintain that in order for those lungs to expand. And have that constant negative pressure to hold those lungs in an expanded position. And that's going to come in real important when y'all talk about chest tubes up in about 3rd or 4th semester. I think it's 4th semester. And here we go, a little fact check. Purpose, true or false, of the cilia is to remove the mucus to the back of the larynx. This is true. Let's try to sweep it up to the back of the larynx where you can cough it up. All right, let's talk about the processes a little bit more. Pulmonary ventilation, that's inspiration and expiration. Expiration occurs when the diaphragm starts relaxing. And those intercostal muscles. Intercostal, remember, is those muscles in between the ribs. You've got the internal ones and the external ones. And they do a lot of work, help bringing those lungs out. I mean, it depends on what kind of shape you're in as to how good a job you can do if your body meets some type of stress because of an alteration in oxygenation. That's why obesity is probably a risk factor for alterations. You know, they talk about it a lot with COVID, lung issues. If you have extra weight or lung problems, then your body's going to have to work harder. And if your lungs or your body's not in shape, then this may give you trouble. You may have different outcomes and different complications. So one thing you need to understand is that when expiration occurs, there's increase in intrathoracic pressure. Air starts to exit the airways, deflates, and the elastic recoil of the lungs is what happens. One respiration should be about a third inspiration and about 2/3 expiration for a normal, healthy human. Does that make sense? Your breath sounds, probably your inspiration on a healthy person should probably be 1/3 of the time of noise you hear, and usually the expiration takes a little longer. Does that make sense? Your body has to work to push out that CO2 and empty out. But ventilation is also known as breathing. This is moving that air in and out. Remember, this is your mechanics. There's 2 phases just mentioned: inspiration, expiration. Inspiration is the active phase of the thing. You've got to have movement of the muscles. You've got to bring that air into the lungs by the use of the thorax. And the expiration is more passive. There's some physical factors that can contribute to airflow in and out of the lungs. The condition of the body's musculature, compliance of the lungs is important, and then airway resistance. Condition of the body's muscles that are involved in breathing, like accessory muscles in the abdomen, the neck, the back, are so important. And anytime you see muscles that are breathing the opposite of what they should normally be doing during respirations, this is abnormal. It's retractions. Like you may see a patient take a breath in, and you see the muscles in between the ribs retract as they're expanding their lungs. That's not normal. They're working harder to breathe than they should. And you need to recognize that. This is called a retraction. It is abnormal unless you're running a freaking marathon, y'all. All right, so y'all need to start looking at that. I'll say this: lung compliance is something that some students have a harder time understanding. You can look a lot of YouTube videos out there about retractions and see lots of examples and demonstrations out there. It's pretty cool. But lung compliance is, there may be a video about a balloon used to demonstrate a stiff non-compliant lung is a comparison to like a new balloon. It takes a lot more inspiration effort to inflate a brand new balloon versus one that's been used. And so the compliance of the lung is going to affect how easy you can inflate the lungs. And you may see problems with a non-compliant lung with age. Normal changes with age happen. Emphysema is a non-compliant lung. So we have to address those differently, knowing that. Airway resistant is the result of something like impeding or obstructing the airway, maybe where the bronchial diameter width changes, or even stuff like foreign substances, food, coins, toys, liquids, aspiration pneumonia, wheezing, bronchospasm. Those are examples of airway resistance or obstruction. So a decrease in the size of air passages resulting even from things like constriction or poor neck positioning can impede respiration. Asthma is a good example. So consider those things. Here's the other process. I think this is the second one. We've still been talking about ventilation a good bit. But gas exchange is just as important. There's a gas exchange video you can click on this presentation or this PowerPoint in presentation mode and watch, because it may help you kind of get a better grasp on it. But this is the process of gas exchange between the air and the blood, and between the blood and the cells of the body. Oxygen concentration in the capillaries of the lungs is lower than in the alveoli, and due to this concentration gradient, oxygen will diffuse over from the alveoli into the blood. It's kind of like we're hanging out, and this little oxygen wants to do its own thing, wants to go where it's less crowded. And that's what's going to happen because the blood is in need of it. So it'll diffuse over very easily. So the diffuse gases do from areas of high pressure concentration to lower pressures, lower pressure of concentration. It's passive movement of air in and out of those airways, continually replenishing oxygen and removing the CO2 is part of the gas exchange process that happens in the airways and lungs. All right, so which organ is the site of gas exchange? Awesomeness. Everybody should get this. The alveoli. At the end of the bronchioles, terminal bronchioles, there's clusters of them that are the site of gas exchange. Remember, this is the microscopic level of oxygenation. Factors that influence the diffusion of gases in the lungs. And this has kind of been some of the battle with some of your COVID patients, and you'll hear us talk about that a good bit. And you probably will throughout the course of this whole program because it is so new and we are learning so much about it, and it's things that you can apply and see in real life. It's influenced by several things: changes in the surface area that's available, thickening of that alveolar capillary membrane, and then the partial pressures. If anything changes in surface area, like maybe they've removed a lung, this can affect gas exchange. Doesn't that make sense? Maybe even incomplete expansion, like especially after surgery, patients are laying on their back, laying in the bed, and they're not fully being able to use that chest wall to open up those lungs and breathe, and those little alveoli will start sticking together, atelectasis. So that's incomplete expansion, and that changes surface area. So that also changes how much gas you can exchange. Any disease that results in thickening of that alveolar capillary membrane, like pneumonia, pulmonary edema makes diffusion harder. A partial pressure that results from any gas in a mixture depends on the concentration and can affect diffusion. The environment. I mean, oxygen is reduced up in higher altitudes. I've seen them go to the Himalayas with oxygen, or even like, let's think about working in toxic fumes or something. Or, you know, that's just some general examples. You just need to remember, you can knock a patient's drive to breathe out by administering too high levels of oxygen. You know, oxygen is a medication. It has to be prescribed, but I'm gonna get my order later and take care of my patient's acute problem. But toxicity can occur, and we'll talk about it, particularly with your COPD patients, because they trap CO2 because their lungs are so rigid. They're used to higher levels of CO2, and so their drive can be knocked out if we diffuse too much oxygen in there and knock their CO2 levels out too low. So we'll talk about that a little bit more. Let's go on into transport of respiratory gases and perfusion, that last component that ties into that concept of perfusion that Ms. Pittman has. So let's think of perfusion as the transporter. If you ever watched that movie, okay, that's the car. Perfusion is the car. I have to have some type of analogy, like I told y'all. So oxygen transport occurs by perfusion. You got to have hemoglobin and all those little working parts inside the blood doing its thing. And so we're getting in the car and we're going to take the oxygen. And so oxygen crosses the alveolar capillary membrane, gets into the car, and perfuses into the blood. And then once we get the car where it's supposed to go, take the oxygen infuses into areas of higher pressure. And so when we get it transported there, we're dropping off that oxygen and we're picking up that CO2. The hemoglobin kind of works like the driver. And so that can give you kind of a visualization of that. So there's two components to the transports, the drop off and the pickup. And I like this movie Transporter with Jason Statham in it, and that might help you get a better visual visualization, a mind's eye view of it. So I think that maybe would be better than a mule with Clint Eastwood in it, but it's always a drop off and a pickup. And so the hemoglobin has to be acting correctly. There's some factors that influence the amount of blood flowing through the lungs, the amount of blood present in the area of the lungs. It depends on position, sitting, standing, or lying down. Perfusion is always greater in dependent areas. Perfusion of the lung tissue is always greater depending on activity level. Increased activity, you're going to have increased need for you're going to have increased need for oxygen. And I hope that just makes good sense to you guys. So perfusion is dependent on adequate blood supply and a properly functioning cardiovascular system to carry these gases around, y'all. We're just amazing. Let's talk a little bit more about regulation of the respiratory center. I kind of talked about this just briefly, but there's a center in the brain, in the medulla, in the brainstem, immediately above the spinal cord. It's stimulated by increased concentration of CO2 and hydrogen ions. This is your centers for the drive to breathe. Okay, it's like your computer. It tells your body what to do. Okay, so it's picking up how much CO2 is in the blood, and it kind of regulates the respiratory rate and all the things your body's doing to oxygenate from the medulla. So these patients, it'll tell the body, you need to increase the rate and depth of ventilation. You need to blow off more CO2, just depending on what the needs are. So yeah, breathing is voluntary and also has some involuntary processes, and it comes straight from the brain. And so patients that have high CO2 levels, like COPD, they're just used to that trapping. The chemoreceptors in the brain kind of become desensitized. And so you can't give them large amounts of oxygen because it'll knock their drive to breathe completely out. So remember that, you guys. Here's a fact check. Pulmonary ventilation is the process by which oxygenated blood, capillary blood, passes through the body tissues. You better get this. It's false. That is perfusion. We just talked about that. You remember? You got to have your transporter. That's part of perfusion. You got to have your car and your driver and all those things working together. Got to have an engine to pump the blood. What is gas exchange between the lung and the blood, and between the blood and the tissues? Take your time. Chicky. So C is the correct answer. It's respiration. This is where gas exchange between the lungs and blood, and then the blood and the tissues occur. That's that second component. We've been talking about 3 mechanisms. This is the second one. Diffusion is the exchange of oxygen and carbon dioxide, remember, at the alveolar capillary membrane. And perfusion is the arterial venous circulation in the pulmonary capillaries with the blood. And then there's the ventilation. That's that in and out of air. That's the mechanical component, okay? Don't let these words trick you up. You got this. Here's some terms we use for alterations in respiratory functions as well. You need to memorize these. If you don't understand terminology, it will be the death of you in any of these concepts. So spend just a few minutes, make you some flashcards. I'm sure they're already out there on Quizlet, y'all. I know about Quizlet. It's great. If not, make you some. That may not be what you like to do, so get you some index cards and make your own. Remember, we've talked about the 3 physiological processes that occur. And so when a hypoxia occurs, there's symptoms that may hypoxia, not enough blood, low, not enough oxygen, low oxygen is what that term means in the cell. So they'll have symptoms like dyspnea. Their blood pressure may go up. They have a small pulse pressure. You don't remember what that is from vital signs, you need to go back and study it. They'll have increased respiratory rate, pulse may go up. They may be pallor, they have cyanosis. They may exhibit signs and symptoms of anxiety, restlessness, confusion, drowsiness. Very common with hypoxia. And hypoxia can be caused by hypoventilation. They're not breathing fast enough. This is very common in surgical patients or patients taking opioids. It decreases their respirations because of the way it acts on the brains, and so this can be dangerous. Thus the need for naloxone. And so make sure you're monitoring these patients' respiratory rates before and after administering opioids. You can kill them. Effects of chronic hypoxia can be seen in all body systems. Some signs and symptoms you may notice are altered thought processes. They may have headaches. I mean, the brain has got to have oxygen, y'all. It hurts. It'll start dying. Chest pain, enlarged hearts occur from chronic hypoxia. Clubbing of the fingers and toes. Lots of different pictures out there in your book and online that show you these types of alterations. They may have anorexia, don't have an appetite. I mean, if you can't breathe, then that is not your focus. Food is not your focus. Constipation, because your body shifts from taking care of those processes to more immediate needs like oxygenating, decrease urinary output, decreased libido, weakness of extremities, muscles, and muscle pain. Your elderly may only exhibit symptoms of confusion with early hypoxia. So you've got to catch it early. Let's talk about the relationships between oxygenation and other concepts. Already kind of talked about hypoxia. It can affect cognition, changes in mental state, mainly confusion with your elderly, anxious. Let's talk about elimination, constipation, and anorexia. That just makes sense, right? We've just kind of mentioned that. Acid base. Your lungs are your regulators of CO2 release, and that is your acid component. You'll learn more about acid base over into second semester. Inflammation, your respiratory system is kind of weak, easy to attack, very sensitive. It's very sensitive to irritants and allergens. You have cilia, mucus enzymes to protect you. Mobility, shortness of breath. You may see patients that have alterations in oxygenation. They get short of breath with exertion. Can't move around as well. They can't walk far. You may have to alter their activities or alternate activities with rest before meals. Position may be important with this. So sit them upright so they can breathe easier. And it says that actually laying them down is probably your second best position, but it really depends on what's going on with the patient because it's supposedly you can ventilate better, and actually blood flow will be better, so perfusion would be better. It's just harder for your lungs to expand when you're lying down. Increased work of breathing. Let's talk about nutrition. Oh, let me go back to mobility. Sometimes they can't move the air, COPD patients, so a fan might make it easier for them to breathe because it can help them ventilate in a way that their body can no longer do as well. Let's talk about nutrition. Increased work of breathing requires lots of energies. You got to allow rest before meals. If the patient's dyspneic, they can't eat. Maybe they need high calorie, high protein, smaller meals. Always making sure you're providing oral care to help them get rid of that. If they have sputum taste sensations that can cause anorexia, you might want to do some good oral care before meals. Cardiovascular system is very interrelated to oxygenation. We've already kind of talked about it repeatedly, but the heart's the pump, your vessels are your transport tubes and lines for gas exchanges. Alterations in the cardiovascular function that can affect oxygenation could be things like dysrhythmias, arrhythmias, which are abnormal heart rhythms, myocardial ischemia, which is lack of oxygen to the heart muscle, angina or angina, the heart attack, or the layman's term is heart attack, but myocardial infarction or heart failure, those can complicate the oxygenation to the body because the heart is the pump, and if it's ineffective, then we've got issues. Factors affecting oxygenation, other than overlapping concepts and body systems, are things like the level of health, having acute or chronic illness, for example, like renal or cardiac, do complicate the respiratory function. These in particular, ones that I just mentioned, can cause fluid overload and thus impair tissue perfusion. Chronic illnesses that lead to muscle wasting or poor muscle tone, including the respiratory muscles, can affect oxygenation. Anemia can lead to inadequate O2 to the tissues, decreased hemoglobin, decreased cardiac carbon dioxide exchange, all because of the anemias. A myocardial infarction causes a lack of blood to the heart muscle and then damages the heart, which is actually an oxygenation issue, perfusion issue as well. And then you've got a decreased effective pump because the heart is damaged. So we've got decreased perfusion when the pump is not working as well, and then thus we have decreased gas exchange and oxygenation. Spinal issues like scoliosis, pectus excavatum, the chest have some abnormalities, cause changes in breathing patterns and air trapping. Maybe they can't take deep breaths, restrictive chest capacity. Obesity and chronic bronchitis are correlated, they think. Often these patients have shortness of breath during activity and they exercise less. And the alveoli really very rarely fully expand. And then we're going to talk about developmental considerations when we talk about children. Medications should be considered, especially the opioids, since any type of CNS depressant or drug that works in the medullary respiratory centers of the brain. Also, other medications decrease the heart rate, can also affect blood flow to the body tissues. Lifestyle considerations, the activity level of your patient. Are they sedentary? What type of habits do they have? A person that exercises 3 to 6 times a week can better respond to respiratory stressors. Culture and lifestyle determine health choices. Cigarette smoke. Nurses need to role model this. And when you go to the American Heart Association, it talks about e-cigarettes and vaping. A lot of these companies are promoting it as it's a better option than smoking, but it is not. There's still harmful substances in the vapes, and nicotine is still addictive, and that's what the e-cigarettes have in them. So they're still have health risk associated with them because nicotine is a vasoconstrictor and very potent. So Then environmental considerations. Do you live in a, check your patient, what kind of air pollution hazards do they have? It can lead to lung cancer and lung disease. Occupational hazards, are they exposed to asbestos, silica, coal dust? These things lead to chronic pulmonary disease. Is there chronic exposure to radon, radiation, asbestos, arsenic? All that can lead to lung cancer. You've got to look at the environment. And then psychological health considerations. Stress can increase patients and make them hyperventilate, can lead to lower levels of carbon dioxide in the blood. And did you know that general anxiety can lead to bronchospasm, especially in asthmatics? It can be a trigger. Let's get into the developmental. Here's the infant. You need to review your vital signs for the ages and stages. You're not going to recognize whether they get in distress if you don't remember what's an appropriate range for vital signs in an infant, child, adolescent. Child has some anatomical differences. Chest is smaller, airways are shorter. Aspiration is always a concern. They're always putting stuff in their mouth. Rapid respiratory rates usually are common with them. They have an increased number of alveoli and size. And surfactant, remember in utero, we talked about it, should occur between 34 and 36 weeks. But before 34 weeks, it's not sufficient. And so we may have to give them surfactant because the alveoli will collapse. Infants are more at risk for upper respiratory infections and asthma due to secondhand smoke. They usually are more abdominal breathers. Their pulse rates are higher. Respiratory rates are a little bit higher than other ages and stages. You want to limit, and these children infants can't really respond to stress. They don't do well with stress. Their heart rate's already high, and there's really not going to, be much more cardiac output they can get by increasing their rate. So, they stress easier, older people and babies. Here's the child. There's some anatomical differences. Usually these are your toddlers, preschoolers, school age, and even getting into adolescence. We're talking about changes that kind of span that time. Elongated, less angular bronchioles or eustachian tubes in their ears. As well, the exposure to daycare and school germs, you need to teach them good hand hygiene, tissue etiquette. Some serious problems with otitis media, bronchitis, and pneumonia may be found during these times. Asthma, you need to monitor for that as it starts developing in childhood because they have immature immune systems, and it'll develop, if that's the case, into late childhood and even early adulthood. Their blood pressure will increase over time as their vessels turn into adult size. Older adults, you need to spend some time on page 1490 in your fundamentals text. It talks about age-related changes on that. It's focused on the older adult. There's some prevention. We need to encourage anybody that's smoking to stop smoking. And talk about secondhand smoke and teach them infection control practices. Get your vaccines, the pneumococcal and flu vaccine in particular. They have decreased recoil of the chest, less air exchange, reduced elasticity. There's probably a good 10 or 12, 15 maybe different age-related changes that have some really good nursing strategies I want you to spend some time on. Talks about teaching them to avoid milk products if they're troublesome, especially with secretions. Use cool mist humidifiers, anything to help these patients if they have a cough or drier mucus. Their mucous membranes are just drier with age, and they don't have the same thirst response, so we need to encourage them to drink. Spend some time in that so that you understand how to address the needs of your older adult. Pregnancy. There's some changes in pregnancies, this comes straight out of your maternal child book, which we don't use a whole lot, but we're talking about your objectives, and it talks about the lifespan. And so, we've got to talk about pregnancy. There's blood volume goes up, changes in the body shape and size, decreases the thorax space because the baby's growing. So these mamas you may see their nose flaring towards the end of pregnancy, and they use the diaphragm a good bit more. Muscles start to relax later in pregnancy because of hormones, and so um, sometimes these ladies may find it easier to sleep lying up or on their side. So there's some neat changes that affect that happen during pregnancy that you need to realize affect oxygenation, not only of the mother, but can also affect the fetus. You know, mothers are more prone to estrogen changes, the vasculature, respiratory tract, and mamas will have nosebleeds and sound stuffy, especially when you get in the second, third trimester.